evening and welcome to the Ombudsman program, coming to you from Dayton, Ohio. I am Chip Wilkins. I'm a long-term care ombudsman and director of a program here in Region 2. And tonight we are going to tell you all you ever wanted to know about COVID in long-term care facilities and what it has been like and the changes that have occurred because of COVID and really how the state has navigated through that. On this February 14th, first want to say happy Valentine's Day to everyone and introduce our guests. Tonight we have with us the Deputy State Ombudsman, Erin Pettegrew, State Long-Term Care Ombudsman, and also from Cincinnati, we have the Long-Term Care Ombudsman program in Region 1, and Bob Vines is here with us. So, Erin, why don't you start off and tell us what is a state ombudsman? What is that role, and tell us a little bit about the jurisdiction you have.
Sure. Hi, Chip, and thank you for having us. We are so excited to be with all of your followers out there in the Dayton area. As Chip said, I'm Erin Pettegrew, and I'm with the State Long-Term Care Ombudsman Office. We are one of more than 50 ombudsman programs across the country. We are required by federal law back in the 1965 Older Americans Act required the establishment of an ombudsman program in every state and the territories, which is why I said more than 50. I can count. But in Ohio, that office is based out of the Ohio Department of Aging in Columbus, Ohio. And then we have 12 regions around the state. And so as Chip mentioned, he's in our second region, number 2, which is the Dayton area and the surrounding counties. And then Bob represents our Region 1 down in the southern counties below you on the map. So we have those 12 regions, and then we've got a small state staff. We represent residents of long-term care facilities like assisted living, nursing homes, even some of the smaller group homes. And then we stretch out also into the community. So we also represent home and community-based service consumers like Meals on Wheels or adult day services, any of those home and community-based services that allow you to live independently in your own home.
Got it. Thank you. And Bob, we heard you're in Region 1. What are the counties that you serve there in Region 1?
We serve the 5 counties in Southwest Ohio. It would be Claremont, Clinton, Butler, Warren, Hamilton counties.
Got it. And as a program director in Region 1, tell us a little bit about what it is your staff does.
Well, my staff will advocate for residents in long-term care settings. That would be nursing homes, assisted living facilities, small group homes, licensed by the Department of Mental Health and Addiction Services. And also, we will help My Care residents in as your area does also. My Care Ohio folks in our counties are served through our office as well.
And you said My Care, and we won't go deep into it, but what is My Care?
Managed system of for folks that are duly eligible on Medicaid and Medicare. Both in the community and long-term care settings. So folks with that insurance will be, if they have an issue with any of their services or their managed care system, we will help them out.
Got it. And just in general, Bob, what are some of the types of complaints that folks can call the Ombudsman's office about?
Well, anything related to care, obviously, whether you're getting your baths or you're getting your medications on time, or whether your meals are cold or hot, and anything at all, really. We handle involuntary discharges, just being treated with dignity and respect.
Very good. Now, Erin, as the state ombudsman and in the state office, do you handle complaints, or what is the role in the state office?
That's a good question, Chip. We do rely on our regional programs to handle the individual complaints that are raised by people living in those long-term care settings. But we also do a lot to raise the voice of those consumers statewide and even in the federal level. So we attend a lot of meetings, but we do go to represent consumers before the legislature. We advocate for them to receive better benefits and services. We try to get out as many educational opportunities as we can for residents and the staff. So we support our regional programs, and so we do participate in their training. So we get all the new staff who come in to be ombudsmen, and we help train them. We also develop curriculum for the volunteer ombudsman that we rely on quite a bit in our communities. And then we help with running our long-term care consumer guide website. So we have a website where people can go and look for quality indicators about what kind of care is being offered in those same homes, and try to steer people toward the quality homes that are out there for them.
And I will add this to the consumer guide because, really before I came to the world of ombudsman, I didn't know a lot about the consumer guide, but it is really a great tool for folks who may be looking for the right nursing home or assisted living facility. You can go and, put 3 facilities that you want to look at and compare side by side. You can do that. It's a fantastic tool. And is that run by the ombudsman?
It is. And one of the unique things that Ohio does that almost no other states do is conduct resident satisfaction surveys every other year. And we conduct family satisfaction surveys in the alternating years. So right now we're actually in the field collecting surveys of the family members of the people living in long-term care. So we send out 80,000 or so surveys. We receive the results back, and then we publish the combined answers. So you can go and see what people who are living in those homes feel about all those same services that Bob was talking about. So are they getting good care? Are the getting hot food served hot? Are they being treated with dignity and respect? Are their rooms kept clean? So all of those things are available for you to peruse. So we publish those scores. Unfortunately, our resident survey got cut short because of the COVID pandemic, but we are back in the field with those family surveys now because those are mailed out. We felt that was a little safer to start back with, but hopefully we'll be back in the field doing the resident surveys too next year.
It is a wonderful tool for anyone that's looking to long-term care and wants to really get a deep dive into the world of long-term care. Just go to Google and search Ohio Consumer Guide or Ohio Long-Term Care Consumer Guide, and it'll pop right up. It really is a wonderful tool. Now,
such an easy website. I even have it memorized, ltc.ohio.gov. If I can remember it, so can you.
Well, you spoke about COVID, and I want to take you back to March of 2020, and I'll never forget the beginning of March. I didn't really appreciate the fact that we were about to have our worlds change so dramatically. But by the end of March, things were much different. And when was it that you were told, and Bob, I'll go to you for this, just approximate when you could no longer go into long-term care facilities because of COVID?
I recollect it was about March of that year. Things sort of shut down. and that no one really, it was all kind of new, no one really knew how to approach it and what it would mean. So for that month of March, we sort of stayed out and did a lot of phone calls, families.
Right. And Erin, was that true across the state? Were most of the ombudsmen around the state unable to go into facilities towards the end of March?
Yeah, if I have the dates correct, it was somewhere around the middle of March. We received a notice that we were going to halt visitation to the facilities, and it was very hard because, as Bob said, a lot of what we do is going in buildings to see people in person. So to tell a bunch of advocates who are passionate about the people they work with that they can't do the function of their job, and needed to transition to a virtual advocacy was very difficult. A lot of the people we work with don't have personal cell phones, and they rely on facility staff to bring them a telephone, help them dial out. So a lot of those virtual communication techniques were hard to do. So we tried our best to get resident lists, get family lists from the staff, and just start calling. So we were using up our minutes pretty quickly that month.
Well, I recall here in the Dayton area in Region 2, that was our best contact with the residents at first, was talking to family members and getting a list of contacts of all the residents and all of their family members, and then reaching out to the families and trying to give reassurance, but at the same time find out what kind of concerns they were hearing about from their loved ones. Bob, I imagine it was similar for you.
Yeah, right. It was very difficult because, as Erin said, a lot of our advocacy is based on what we see when we go inside of a building, and talking with the residents and building that rapport. When you can't do that, and you have to start relying on, technology, there were glitches, and we have a big learning curve, of course. Then I recall it was sometimes even difficult to get the facilities. Give us your census, give us your family list. Of course, we do have the right to have those things, but it was a learning curve for everybody.
And I imagine at this time, when you weren't able to go in, and across the state, residents were probably unable to have visitors as well. Is that accurate?
Yeah, at first.
And how did when were they first able to start having any kind of visitation, and what type of visitation did they start with?
Soon after the initial shutdowns, they started talking about something called compassionate care visits. And that was the opportunity for family and loved ones to go into the homes and visit with people who were really struggling. So that could have been because they were at the end of life, or they were suffering because of that lack of communication with their families. Maybe they had visual or hearing impairments where, telephone conversations or virtual communication on an iPad or through a window weren't sufficient. People who were really struggling with depression or anxiety, we could advocate for these compassionate care visits. And so Ombudsman came into play quite a bit in that time, because facilities were understandably very cautious about letting people in. This was before any of us were vaccinated. Residents were already extremely susceptible to COVID. And so we had just so many people really grieving that loss of in-person communication. And so they reached out to Ombudsman, and we got on the phone with our colleagues over at the Ohio Department of Health who, were intimately involved with some of those complaints as well. Joint instructions from the Department of Aging and Health gave residents the right to these compassionate care visits, and we had to advocate for those. We had to tell facilities that put PPE on us, make us as safe as possible, but we have to get in there to be able to see residents.
With the compassionate care visits, there were certainly folks I know who were at the end of life and passing away, and people wanted to have the opportunity to say goodbye to their loved ones and grieve there with family. But in that regard, we've had a question that came in, and I should reiterate that tonight's show is live tonight on February 14th, and we are taking calls. The number to call is 937-223-5311, 223-5311. Please feel free to call in with questions. The first question that a caller has asked is, how many people have died in nursing homes from COVID? I know that we've heard so much about nursing homes kind of being a very vulnerable area. And so, Erin, do you have any idea or numbers there?
I do. I was recently looking at that exact number. So the count at my last check, which I think was a week or so ago, was around 8,500. So more than 8,000 people living in a long-term care facility had died due to COVID. Now, some of those numbers might even be underreported because the facilities weren't required to report that for several months after the first of the pandemic. So there may be a few more than that, but that's the number I'd last seen on the COVID dashboard that the state of Ohio has.
And that's a great point, Erin, that we should probably let the viewers know about. The Ohio has a dashboard. Can folks go and look at that dashboard and get information about nursing homes and COVID?
Right. There's a coronavirus.ohio.gov, I believe is the address. And they have several dashboards. And so you can look by long-term care facility. You can see what their current COVID outbreak status might be. You can see what their past COVID outbreaks have been. So I have to warn you, some of those numbers seem extremely high because some facilities specialized in caring for folks with COVID. So they voluntarily took people in who had COVID. So their numbers seem sky high. It's not because they had terrible infection control practices, but they were intentionally taking people with COVID to help relieve the long-term care system. But you can go and look, and thankfully those numbers are a lot lower than they have been, but they're still much higher than we would prefer. So where we were seeing cases of dozens of people in a facility coming down with COVID, now you're seeing 3 to 5 at a time, and unfortunately we're not seeing as many serious illnesses and deaths now that many residents have been vaccinated.
Bob, turning for a moment to the looking at what the residents were facing early on in the pandemic, the visitations we know were limited, and we talked some about the compassionate care visits. What were the other methods by which families could try and see their loved one in nursing homes?
Well, early on, it was difficult to see them at all. And lots of facilities just shut down visitation whatsoever. And then they began to allow the compassionate care visits. And then, after a little bit, we started having window visits where you could come sit by, the window. As long as your family member was on the first floor, I guess that was okay. And of course, we were talking about middle of March. Erin is right; it was the middle of March, 20 that first started happening. But as the weather got warmer, we began. The Ombudsman office began, I think, in April in Cincinnati, to have outside visits, and families could do that. limited way. They used to restrict how many people could come and how long they could stay and that kind of thing. And the thing about it was as I recall, it was the checkerboard approach. It was all over the place as to what sort of policies and procedures in the facility. You never knew what kind of policy one facility might have. And they were all saying, well, the state says we got to do this, and the state saying, no, we didn't. We never said any such thing. And so it was a hodgepodge of policies and procedures, and unevenly applied, within the facility. Because one day it might be they'd let people come to the window and talk, and the next day they'd say no kids are allowed to come. People would come from far, far away to visit because they were very concerned. Staff started getting.
I recall an incident with a family member that had driven from Tennessee to come up and see their sister. And this was at a point in time when it was July of 2020. So we were, 6 months into COVID or so, and outdoor visits were being permitted at that time. But they came, the family did, to see their loved one, got to the facility and learned that their family member had been to a doctor's visit 2 days earlier. And because of that, the individual was being quarantined. And at that point, it was a 14-day quarantine, and they would not bend the rules. But thankfully, the family did contact the Ombudsman's office, and we were able to advocate for the family to at least be able to do a window visit. And they brought the resident down from the third floor in that situation, and they were able to visit. But so many stories of frustration like that.
Mm-hmm. Mm-hmm.
If you went outside to see somebody or went to the doctor's office, sometimes they would put you on quarantine for 14 days. Anytime you had contact with the outer community, and that added a strain.
Well, I think it's important, Erin, to let folks know, there are infection protocols, but there are some unique characteristics, aren't there, about nursing homes that lend themselves to the spread of a virus. If you could just touch on that for a second and explain that to viewers.
Sure. Well, because of the condition of the folks in nursing homes, they are, by definition, already probably susceptible to a virus like this. Many of them are living with chronic conditions, COPD, emphysema, cancer, various other conditions that make them more susceptible to serious illness and death. But also just the conditions of living in a nursing home, any nursing home. You're living in close quarters. Most people in a nursing home have a roommate. Some nursing homes have moved toward more private rooms, but the majority of folks, they have double rooms. Some even have bigger than that, but double rooms is very common. And then you've got staff going from room to room. So you've got one staff member who might go from one room, take a temperature, give some insulin, or help deliver a meal to one resident, and then go out, and they should, hand hygiene. And back in before vaccines were available, they were doing a lot of gowns and so a lot of just opportunities for the virus to spread. Shared spaces, shared bathrooms, shared shower rooms. And then you have the staff who are going home to their families, and they might have, children who picked up a bug at school or something, and then they bring it back into the facility. So, we had, of course, a couple of tragic situations where a staff person came in and unknowingly could go from room to room and unfortunately spread this virus. So it's just something that is very dangerous to those residents in particular, but also just the conditions of living in communal living like that make it very, very easy to spread.
Absolutely. The residents, we know that because of the conditions they were in, the susceptibility to infection, that there were a lot of limitations put on the visitation, and I think that's clear. And we'll tell the viewers that that has changed, and we'll talk about that in a moment, but visitation is back in full swing. But Bob, what were some of the things your program did to try and help residents communicate with family, friends, because they couldn't do a lot of in-person visits?
Well, we started to contact families early on and see what their experiences were, and try to communicate about what we knew was going on in the facilities. But to contact directly with somebody, we started to use vehicles like this, platforms that allowed us to have meetings with the families and with the facility and the residents together. We'd use our iPhones to walk around the hallways, and take pictures of things, not people, but just what it looked like inside of the building, that kind of thing. So we use technology. It was still difficult to communicate via a telephone. Staffing became more and more of an issue. As staff members also got sick, and remember, schools closed down, so people would have to stay home with their children and things. It was a difficult time. So it was hard to get anybody to answer the phone, I recall. And sometimes that's still a problem. But
yes, it is.
But yeah, it's still. But I do remember how long it would take for some, because the administrator was answering the phone when they had a chance, or the director of nursing was answering the phone. Anybody and everybody, all hands on deck. Was kind of the situation.
And within the nursing homes themselves, Erin, I know you touched on this about there being residents, or I should say facilities, that would specialize in COVID and would take residents in who were COVID positive. Is there any kind of method by which facilities are separating a COVID positive resident from someone who doesn't have COVID?
Yes, they have some pretty strict rules about that. So if they have completed testing, for instance, and one resident tests positive, they will be moved to an area so that they can't be exposing a roommate or other residents in their immediate area. So they'll have, a positive area, then they'll have a watch area. So they've got people who are sort of under observation to see if they test positive. And then you'll have just the regular population of people who are negative. So we've, facilities have gotten very good over the last 2 years of shuffling folks around. Unfortunately, that's very disruptive to the residents. It's not just a room and a bed, these are their homes. And so they've got personal belongings, they've got their decorations, they've got their comfort items around them. So, all of this is very disruptive, but there are some very closely watched protocols to prevent infection control, so that hopefully those people who do test positive don't get their roommates sick.
Right. That's important. Well, Bob, when you've worked with folks in the greater Cincinnati area, and you're dealing with issues of COVID and COVID spread, you touched on this a little bit earlier, but what were some of the impacts of COVID on the actual staff that support the residents?
Uh, on the nursing home staff, of course, everybody had to learn, how to. There are already infection control policies, PPE, and standard infection control procedures. Hand washing, basically. But people had to, wear those masks, and I don't know if you try to wear an N95 all day, but it is very difficult to do and very constraining. For some people, it's just too difficult. Now there are, mask breaks that they take now and things like that. But as staff started to get, affected by the COVID, because of course they were out in the community doing their thing, and when it started to get the infection rate started to get higher, counties were turning red. You remember things like that. We started to see fewer and fewer staff available. Now that's going to have a direct impact, of course, on resident care. Mm-hmm. But that's staffing has always been an issue in nursing homes, frankly. And I've always said that COVID, didn't create it, but it certainly exposed it, put a lot of pressure on those pipes, as it were. And it's been very hard on the industry, for sure. Mm-hmm. But they have their PPE and their training, and of course our own staff had to brush up on those things. And we, of course, the state offered training through the Ohio Department of Health in conjunction with the Department of Health, and we learned how to doff. That is the word, doff, right? Yeah, PPE and all that, and gloves, and we had to get all this stuff in, and we still have, of course, N95 masks and face shields and goggles and gowns if needed, if we're going to go into a COVID unit.
So you and your staff actually learned how to use PPE, and I imagine you probably have had to use that from when you make your visits.
Absolutely. Absolutely. Facilities, of course, have always been good at screening. That's one of the first things that you go through when you visit, when families go visit. They're going to take your temperature at the door, hopefully, and they're sometimes they ask for cards, and of course we don't have to show. The ombudsman doesn't have to show them proof of vaccination or that sort of thing, but we have all been vaccinated in my staff, so yeah.
Good. And
we've been pretty proud of the fact that we've had ombudsmen going into buildings across the state, and to date, knock on wood, I've not heard of a single ombudsman who's managed to infect anyone in a long-term care facility. So we've been very careful. Fortunately, we don't do any, personal care. We're not right up on residents' faces to breathe on them or anything. So right. we can keep our personal distance. Makes it difficult though when the masks on and shields, when people have hearing impairments and rely on reading lips a little bit to understand us, to stand back and have to yell to be heard.
Right, yeah.
And the going into facilities now, as our staff does, we still to this day are wearing N95s with a shield. And the N95, after about half an hour to an hour, it really gets uncomfortable. And you can't help but feel empathy for the staff that are having to utilize that all day. And I know it is great protection, but it's easy to let that kind of slide for sake of comfort. And I think that's when you end up with a spread of some sort. You don't want to ease that, which, Erin, brings me to a question. And I know that a lot of facilities are constantly in a state of emergency preparedness. They have to have these plans in place. did before COVID hit, was this something that was thought about by the long-term care industry and how to deal with a pandemic, or was this kind of learning on the fly?
That's a great question. I know the state, all of the emergency preparedness groups have long thought about a pandemic, and they talked about maybe a pandemic flu, because they were always thinking back to 1918 flu pandemic that killed so many people, and they thought, well, that might happen again. So they did have some plans in place, and there was talk, but I don't think any of us really thought this was going to happen. So,
Right.
Although people had always talked about infection control, and we talked about it, I think the scale of it, the fast spread, the deadliness of it was surprising to everybody in the industry. I think they might be lying if they said they predicted this.
Right. Absolutely. And Bob, if you look at the period of time when COVID had hit and up to the point when we could get back in for in-person visits, we'll call it, what were the types of complaints that you were receiving from residents or their families during this kind of lockdown period of COVID?
Well, as I know you recall, Chip, at first, many of the complaints were simply about visitation. I'm not allowed to come in and see my mom or dad, and that was terrible. And especially in the cases where a compassionate care visit should have been allowed. We had a gentleman who had contacted us. He was told that he could come in. His mother was actively dying. They let him come in for a few hours and then told him, you got to go home. Well, he called us, and we were able to keep that visitation going, and she did pass a few hours later. So that was a lot of our issues at first. Now, as things went on and staffing was affected, and there still weren't open visitations to the point where you could come in and see and advocate for your own mother. We started seeing things like, like I said earlier, the baths and the activities, of course, was one, because they sort of stopped communal activities, so that people weren't eating together. That caused disruption in dietary service, so meals were an issue often. And as I said, activities. So people would be staying in their rooms, and that would be causing depression. So sometimes you have medication issues associated with it. Behaviors that were, behaviors, I hate the word, but I mean, people would start to be really depressed and isolated, and sometimes that caused issues. So we saw the gambit, really, Chip,
Right.
Just about everything.
One of the interesting things that I noticed, we received a lot of calls in the greater Dayton area about concerns that their family member, their loved one, wasn't getting fed throughout the day. And it really opened my eyes to how important families are in providing not just support and love, but they're actually assisting residents, their family members eat. And it is oftentimes a family member who does it in such a way that their loved one will respond and will be able to eat. And when that was gone, it was a huge impact on the ability of the residents to eat.
That was one of the reasons that you would allow a compassionate care visit. If someone were not eating and began to lose weight and decline as a result, you could allow a compassionate care visit for family support and that sort of thing. Yeah.
I think in the future, it would be very good for the entire industry to start to really document the amount of unpaid family care that's offered. Because I think, we talk about a staffing crisis right now in long-term care. And we need people in the industry, but there was also the removal of all those unpaid family care hours. And so people were coming in, and just as you said, they were helping people to eat at every meal. They were, helping with personal grooming. They were doing mom's nails. They were, switching out her winter to her summer wardrobe. They were just doing these things because they're family, and that's what you do. And then suddenly all of those hours of care were sucked out of the nursing home. And the staff, even if they bolstered the staff a little bit, they wouldn't have ever taken the place of all of those unpaid family care hours. So I think in the future, what would be really nice to think about is documenting in the care plan exactly what the family is doing. Because when all those people left, who took the place? Who took that up? The staff they tried their darndest, but there just weren't enough of them to do all of the hours that the families were doing in the past.
Well, Bob, you mentioned earlier that prior to COVID, that there were concerns already about staffing. And then I think COVID has kind of shined this light a bit on staffing. And this goes to either of you, what is kind of being done, if anything, in the industry to try and improve the staffing in facilities?
Well, there's a few, I'd say, stages. There's the crisis staffing. So the state has created a crisis staffing support element. And so facilities that are struggling with an acute need, so they have no staff coming in over the weekend, or they have lost all their nurses, or maybe they've got an outbreak that's affecting staff, they can call on the state for help in identifying some coverage, just to keep the doors open, to keep everyone fed, to keep the medicine coming. So they can do that as a crisis level. There has also been some funding going directly to the long-term care facilities. And so I know the nursing homes were received $300 million that needed to go directly towards staff support. So they got that money to be able to, either pay retention bonuses or to hire new staff or to raise salaries, anything that they needed to do to keep staff going. And I think the assisted livings received another maybe 30,000 or 30 million. Sorry, don't quote me on that one. But the numbers are up there somewhere. But then in the long term, yes, we need to really look at staff, appealing to the next generation to go into geriatric care, to go into this field. Right now, it seems very scary. Who wants to go into a field where you're going to be worked really hard? You're going to be exposed to a virus that's been very devastating to so many people. So we really need to dig deep and look at what we need to do to make it a safe and welcoming and a rewarding career field for people to choose.
Thanks, Erin. That's a great point, and we really do, I hope, in the future put a focus in schools and universities about the field of geriatrics and what can be done there. We've got another caller question. They ask, what are the protocols in place for the staff in an attempt to avoid reinfecting patients with COVID? So what do staff do to make sure they're not passing COVID from one pet resident to another, or when they come in?
Well, the best thing for all of us to do is to get vaccinated, and get boosted. The federal government has required that staff in nursing homes be vaccinated by next month. So we are looking forward to seeing if the rates increase. Ohio has been lagging behind other states in the number of staff being vaccinated. So that's the biggest thing. And then if they're not vaccinated, or even if they are, we can still get COVID and pass it around.
Right.
Not as much, but we still can. So the biggest thing is, wear those masks properly, the hand hygiene between resident rooms, keeping distance when we can, making sure residents are given their own safety and test frequently. So there's a lot of things that can be put in place to keep it as safe as possible, but vaccinations are really our best bet.
The universal precautions have been around a long time, and they all have all nursing home staff I know have training on that. So hand washing is very important. Wearing that mask with COVID, absolutely.
Mm-hmm.
Yeah,
But number one, as Erin said, is getting that vaccination.
Vaccination, and I never realized how important hand washing was until we did a training at the state office where we washed our hands just our normal way and then put it under a light to see what was still left on our hands from the method of washing. And it was crazy how poorly I myself was washing my hands until then. So that was very eye-opening. And I know the industry is on top of hand washing. This was just chip washing was not going well at that time.
I remember that training. It must have been a very impactful training because we all remember the lights were.
Absolutely. I wish I could have that given
we all
staff.
think we do a good job of, not wiping our, touching our faces. And I've just been watching myself in the camera, and I know I've been touching my face. And then if you don't wash your hands before you go out and touch something else, it's just a dangerous thing. Our nurse friends would be very angry with us.
They would. But one of the, I guess, positives that we can take from COVID is that we've all kind of instilled personal infection control issues, like not touching our mouth with our hands and washing our hands better. All of that is great, but I'd still rather have dirtier hands and not have gone through COVID. But we deal with what we have to. Bob, are you back in facilities now? Are you able to get in face to face with residents?
Yeah, we've been back in for some time now. I'm sure Erin knows the history of the orders, the so on and so forth. We had 6 or 7 governor's orders on visitation and whatnot, and CDC guidelines and this and that. But finally, yeah, we are as an organization back into nursing facilities. We were long ago recognized as government representatives, as essential personnel. So, there had to be somebody that was, for a long time, as you all know, the Ohio Department of Health, which licenses and inspects the facilities, had suspended their surveys. So we felt it was hugely important for somebody other than staff to get in there and lay eyes on what we needed to see. So we've been back in for a little while, and good thing that we are. We still see really terrible things, sometimes. So it's important to get out there and be there.
I was going to ask both of you about that.
Yeah, I think it's
what
important
you've
to share that
seen
all residents should be getting visits.
What's that, Erin?
I was just going to share that we've talked a lot about visitation restrictions, but as of November, there are no restrictions any longer. Families can see residents. It is open, so you need to.
That was a great day.
Haven't been back. You need to go back.
Yeah.
Everyone is able to go back, and it is no longer whether or not you can go at certain times. It's you can go back all the time now. And since you've been back uh, into facilities, we all have now. Um, what are some of the uh, complaints that are in, and what have you noticed that is uh, the most surprising about what you've seen in facilities uh, post COVID since you've been in facilities?
There's been a number of things. What I would say is, it's not just nursing staff, of course, that have been affected um, by COVID. It's the activity staff. Um, and that has affected, of course, all kinds of things like the residents' ability to get together and have a resident council and discuss the issues that have been going on. So those have been curtailed, but also dietary. And again, we still have issues with, we had recently had an issue where there wasn't any staff for the evening meal. The facility did respond appropriately and brought in food, from the outside. So that was good. But housekeeping is something that concerns me a lot. I was in a facility the other day, and well, it just wasn't as clean as it should be. There's not that regular housekeeping staff going in there and mopping every day, or it doesn't appear to be. So those things, and they mean a lot because the rooms are disheveled. The residents, unfortunately, in some of the places that we've seen are still in their bedclothes in the middle of the day, and this sort of thing. So there's a long way to go, and there's been a lot of pressure put on the staff of facilities and on families, and certainly the residents, right? So it's been difficult, very difficult. But we're seeing the same things we used to see, but more of it and maybe more acute.
I think you covered a lot there. Anything to add on that, Erin, or is anything new that has been seen across the state, or is it pretty much the
Yeah, I think
same in each?
what Bob said was happening. The visitation concerns have dropped quite a bit because of the relaxation of the restrictions, but the complaints about neglect, some care services, the call light waits, those concerns, I think all tie back to a lack of staffing.
Right.
But we continue to work on those, both here and at the state level, so that we can raise awareness of all of these issues and come on programs like this to share that information with everyone.
Yeah, I think that's important to remind the viewers that if they have concerns about their loved one in a nursing home or assisted living facility, that they need an advocate. That is what the Ombudsman program is for. And it's very easy to find us in the various books. So I think that is something that we want to encourage our viewers to reach out and call, because that's why we're here. And we're doing this because it is something that is near and dear to our hearts, and I know many of the viewers. Well, Erin and Bob, I want to thank you all both for joining tonight. This has flown by. I can't believe it's time to exit, but thank you both very much. And on behalf of the Ombudsman Office, we thank you all for tuning in tonight and hope you have a great week.